Describing to you aspects related to the GI tract. I'll begin the discussion by describing an unconventional topic, that is bleeding from the gut. You are familiar about the fact that upper GI bleeding versus lower GI bleeding, the anatomical landmark that we use is called as ligament or trites. While I jotted down, I want to highlight the fact that because nowadays the questions that come out of the integrated variety, so they can definitely mix up the information of anatomy with that of the clinical sciences. Therefore, you have to remember the fact that if the bleed will be occurring proximal to the duodenojejunal flexure, that's where the ligament or trites is present, then we're going to call it a upper GI bleed. Distal to that is the lower GI. When a patient comes to your hospital puking blood, it's going to be a scary situation. You will have to put a wide bore cannula, manage the shock component of the person. I'm going to put up a question to you guys here because I know the fact that the leading cause of hematemesis is peptic ulcer disease that you're aware of. Can you think of the least common cause for upper GI bleeding? As I'll describe to you the data, you will notice that I'll be describing the lesions in decreasing order of importance. The most common one is peptic ulcer disease. The question in your mind should be, what is the least common cause? If you read the topic from any of the textbooks or maybe you've attended some classes. Please remember the fact that when it comes to peptic ulcer disease, it's literally gonna be a fountain, a gush of blood in the gut. It could either be a bleeding duodenal ulcer, it could be a gastric ulcer. Though gastric ulcer versus duodenal, I want you to understand that perforation is something that you commonly see with the duodenal ulcer if it is anteriorly located. But if the duodenal ulcer is posteriorly located, then it can erode into the gastroduodenal artery and there can be a torrential hemorrhage which can even cause the person to reach your hospital with unrecordable blood pressure. Whenever you read about a bleed anywhere in the body, then you should always know the source. In duodenal ulcer, it is the breach of the wall of the gastroduodenal artery, whereas gastric ulcer is commonly located on the lesser curvature. It's close to incisura angularis. The blood vessel that can be eroded in this case would be the left gastric artery. And as I said, this is going to be a torrential hemorrhage and the person might be brought into your hospital with unrecordable blood pressure. So you will put a wide bore cannula. Wide bore cannula would mean that you would be putting, let me say, a gray cannula, not a green one, a gray cannula. Ideally, you should be putting an orange one. But for putting an orange cannula, a doctor should have taken a training of ATLS, that is Advanced Trauma Life Support. If a doctor is not trained well, you might waste a expensive orange cannula. That's the widest bore available. So instead of that, you can be using subsequently a gray cannula. Now you've secured the gray cannula in place, and what are you going to give to this patient? Initially, you're going to give fluids. But if he talks about a patient who is a crashing patient, by crashing I mean systolic blood pressure is lesser than 90 millimeters going down to 70, 60 or even a ridiculously lower values, you know that the autoregulation of the brain is getting compromised. You need to treat the hypovolemic shock of this person on a war footing. So you've definitely put in the gray cannula in the site, you've rushed IV fluids, you've given a bolus of normal saline to this patient, but the main treatment for this bleeding patient would be to initiate massive blood transfusion. Massive blood transfusion is itself a lecture that I've taken in hematology. Here I've just used the short form. Massive transfusion protocol should always be taking precedence over anything else. You can manage the bleeder subsequently. At the moment, my focus will be to ensure hemodynamic stability of this person. So portion a bolus of fluid, give massive transfusion protocol, give packed RBCs, give this guy subsequently again repeat packed RBCs and try to bring the blood pressure back to normal. I could have said whole blood also, but most of the time in hospitals, in massive transfusion protocol, it is blood components that are used. Once hemodynamic stability is achieved, then you will go in for a upper J endoscopy of this person, and you would be able to visualize the ulcer bleeding. You can inject adrenaline at the base of the ulcer that will cause vasoconstriction action, and then we can do a cauterization of the base of the ulcer. So most of the time when it comes to a bleeding peptic ulcer disease, subsequently after hemodynamic stability, you need to control the bleed. When this facility was not available, it had to be surgically done. So the person was taken to the OT, a laparotomy used to be done, and we used to locate the bleeder and ligate it. The number one cause of puking of blood by any patient is peptic ulcer disease, after which you should remember it as drug-induced gastritis. I am talking about erosive gastritis now. H. pylori causes non-erosive gastritis, but drug-induced gastritis would mainly be thanks to the security system. The prostaglandins are gonna play a stomach protective role if you're prescribing COX-1 inhibitors to a person on a long-term basis, or a person is abusing painkillers. Like a obese lady, she's having osteoarthritis of the knees, so you had advised a total knee replacement. Now, Indian patients are Indian patients. She thought the doctor is trying to earn money or commission or something like that, so she did not get surgery done. If you do not get surgery done, when you require a TKR, the joint space is reduced, well, she won't be able to even go to the washroom. So, for her to be in a position to go about her daily activities, she'll start popping in painkillers. And subsequently, the drug-induced gastritis, the erosive gastritis component, can cause her to even develop vomiting of blood. Only then should you answer portal hypertension. So don't straight away answer portal hypertension as a leading cause. Yes, please remember the fact that if a multiple choice question begins by saying that a person landed up in a hospital right now, the person is having 2 episodes, 3 episodes of vomiting, is going to make it very dramatic and says that on per abdominal examination there is a splenomegaly. That is when you will think in terms of portal hypertension. You don't have a splenomegaly in peptic ulcer disease. Portal hypertension is defined as pressure in the portal vein more than 5 millimeters of mercury. It can go up to 10. Once it goes up to 12, the varices are going to pop off. They're going to rupture. So do remember the fact that in portal hypertension, we are basically talking about rupture of the esophageal varices, and we can prevent them from bleeding also, no? If we diagnose them early. But lots of time in India, you would be having an alcoholic patient who's never visited a hospital. All he does is drink, develops alcoholic cirrhosis, goes into portal hypertension, and then bleeds. So esophageal varices are one of the leading causes for development of vomiting of blood in a person, but that will be answered only if in the question you are having this information of splenomegaly concomitantly given. I want to highlight the fact that if they ask you what is the leading cause of portal hypertension, then you know that this is alcoholic cirrhosis. But this is gonna be damn easy, and obviously the examiner would not like to ask you routine data. So I put up a scenario here. I have a person who is having liver damage but is negative for viral markers, because you're aware of the fact that if it is alcohol not responsible, then the hepatotrophic viruses could contribute to development or damage to the liver. So I'm giving a situation where I have a non-alcoholic patient. He's not even touched alcohol ever in his life. He's having negative viral marker status, like never had any of the hepatotrophic viruses infection. There is no metabolic cause in the patient also, like for example, Wilson disease, hemochromatosis, they are the metabolic causes of the damage to the liver. So I'm ruling out the traditional causes, but still there is cirrhosis in the liver or there is damage in the liver. Well, please remember the fact that if they ask you what is the number one cause of portal hypertension, agreed, alcoholic cirrhosis, but he gave a situation in the exam where he described a person having liver cirrhosis. He said the person is non-alcoholic. He is negative for viral markers. The guy is turning out to be negative for metabolic causes, like you did a ceruloplasmin value, did a 20 for a urinary copper, negative, serum ferritin values are normal. So metabolic causes have also been ruled out. Well, then the reason why he is having cirrhosis and then subsequently a portal hypertension would be answered as cryptogenic cirrhosis. Cryptogenic, as the name suggests, would mean that it is difficult to identify the cause. When I was a student your age, the term that was used to describe cryptogenic cirrhosis, which is the term now, was NCPF, that is non-cirrhotic portal fibrosis. But because these old questions are still available on various online domains, so I thought I should mention this before you. In point number 3, I want to highlight portal hypertension, pressure more than 5 millimeter. Once the pressure goes more than 12, the esophageal varices will pop off. But the point is, if it's not an alcoholic patient, it's negative for viral markers, there's no metabolic cause, then you need to remember as cryptogenic cirrhosis. In the same breath, I would also like to mention the fact that if portal hypertension is asked to you from pediatrics domain, and he says, why would a child have portal hypertension? Why would a child be puking blood and having a splenomegaly? Then from pediatric perspective, the answer would be extrahepatic portal vein obstruction. EHPVO is the usual short form that is used. So I've just done 3 miscellaneous questions here. Alcoholic cirrhosis is obviously number 1. You'll never mess up on that. But in a guy with negative viral markers and the remaining scenario, it's cryptogenic cirrhosis. The pediatric version is EHPVO. And you need to understand what is now going to happen to this person, in a sense that what intervention would be done to control this bleed. Can you tell me the source of bleeding in esophageal varices, guys? The source of blood. I mean, I know it's esophageal veins. Can I have the technical name? The technical name for this would be coronary veins. Again, looks very surprising, no? Because coronary is something that we associate with the heart, but those lower esophageal veins are sometimes referred in anatomy also as coronary veins. And I just want to highlight once again, whenever you are reading about bleed from anywhere, the source of bleeding is something that you have to remember. Let's now talk about what are we gonna do in this particular patient who's having bleeding esophageal varices. I'm gonna decrease the portal vein pressure using octreotide. Had I diagnosed this case earlier in non-bleeding varices, to prevent them from becoming bleeding, we shall be using a non-selective beta blocker, that is propranolol. Yes, the same drug which has been taught to you for prophylaxis of migraine. The same drug that I have discussed as the drug of choice for hypertrophic obstructive cardiomyopathy. Propranolol has been told to you for best for prophylaxis of migraine, best drug when it comes to management of hypertrophic cardiomyopathy. The same molecule is today coming in for management of non-bleeding varices. However, like all Indian patients, he's not gonna come early. Most Indian patients come when it's gonna be really late. In a case of bleeding esophageal varices, to reduce the pressure in the portal veins and the portosystemic collateral circulation, what I need to definitely ensure is that first the pressure in the portal vein should go down. So I'm gonna start the person on an infusion of octreotide. Apart from this, in some MCQs, he may not have octreotide in the options, then answer would be terlipressin. As I've highlighted, all the data that I'm going to give you is in decreasing order of importance. So first it is octreotide, then it's going to be terlipressin. If he says, what is the treatment of choice for bleeding esophageal varices, your answer would be that you would go in for an endoscopy and then go ahead with sclerotherapy. We're gonna inject a sclerosing agent in the veins, which is gonna prevent them from even a rebleeding scenario. Therefore, there are three causes that I've discussed at the moment before you, and the fourth one now comes up, which is gonna be Mallory-Weiss syndrome. You have read about Mallory-Weiss syndrome multiple times in surgery as well. So let me just see whether you can recall the majority of facts. The question is, where is the site of tear? Where is actually the tear present? Because every time when you are reading regarding the manifestations occurring in a patient, you need to know the site of the tear and you also need to know the source of bleeding. Mallory-Weiss syndrome is commonly seen. The clinical history that would be given would be a person who's a hardcore alcoholic. He goes out for drinking with his friends, like they go to a bar and these guys are ordering drinks in large amounts, binge drinking. Or it could be a pregnant lady. She's in the first trimester and she's suffering from hyperemesis gravidarum. Whenever you're gonna read these two statements, that is binge drinking / hyperemesis gravidarum, then in those circumstances, when you read any of the two scenarios and the person is having extensive amount of vomiting, there's a definite possibility that the person will start retching. Now, because there is retching would mean that there is a sound of like the person is trying to vomit. Nothing is gonna come out because he's already vomited multiple times. But now what's gonna happen is that the forceful vomiting can contribute to a tear. So they have asked what is the site of this tear. Remember, it's only a partial thickness tear, no? It's not a through and through rupture. If we are talking about a through and through rupture, that becomes Boyer-Haave syndrome. We talk about Mallory-Weiss. The site of tear in this particular case would be answered by you as the lower esophageal sphincter. If he says, where does the tear start from? Now listen to the technical information. If he says, where does the tear start from? Then the tear will not start from the sphincter, because vomiting is reverse peristalsis. So the bleed is gonna start, or the tear is gonna start actually from the stomach. It's gonna go in a retrograde fashion. That is, it's gonna extend from cardia to the lower esophageal sphincter. Now listen to my next words even more carefully. When you gonna send in a scope, when the camera goes inside, the camera will first go in the esophagus and then in the stomach. So for you, when you send in the scope, the tear will appear at the sphincter, but actually the sphincter is subsequently involved. The tear starts from the cardia. So there are two separate aspects. Where is the tear visualized? When you go in for endoscopy, yes, the lower esophageal sphincter, but actually it started from the cardia in a reverse direction. The reverse peristalsis contributed to it. So whenever you read a question of this particular scenario, alcoholic followed by binge drinking, I have explained in cardiology, right? Alcoholic binge drinking, you need to think in terms of possibility of atrial fibrillation and holiday heart syndrome. But today I'm saying that this guy or this lady who's having hyperemesis gravidarum, they just vomited, and in fact with vomitus came blood. The moment the person saw blood, this person might freak out and they might even be loss of consciousness. They might be vasovagal syncope in the person. I'll highlight the statement once again. Whenever you read a question in which it is given retching in a patient, it could be any of the two scenarios, retching in a person, and then talks about vomiting of blood, this can freak out anybody, irrespective of the age group. Howsoever, you consider yourself to be tough. If there's gonna be blood in the vomitus, it's gonna make everybody feel very nervous. So there was a loss of consciousness in this person. Vasovagal syncope will definitely be or can be present. It may or may not be, so I'm just writing plus minus. When this person reached my hospital, I did a quick examination of the vitals. The heart rate was dramatically increased to, let me say, 110 per minute. The blood pressure of this patient was at the moment on the lower side. Let me give you a value of 100 by 70 or 110 by 70. So what I'm trying to say is that per se in malarious syndrome, though looking at that blood, it might look it is in very large amounts and the person might even freak out and might become unconscious. But usually you do not have person going into shock. Why? Because in this particular case, the tear which is present is submucosal. No? You do not have a direct arterial access, or maybe branches of the artery might be involved. Malarious syndrome, guys, is a self-limiting condition. It's a submucosal tear that is present. So as such, the threat to life with malarious will be relatively lesser. This explains the fact that why in this person, by the time they reach the casualty, the person is up and awake, and with conservative management, the patient will recover. Malarious syndrome is a self-limiting condition. The submucosal tear will not cause any threat to life, but if the bleed reoccurs, like he puked once again and the blood came maybe in slightly increased amount this time, then you obviously need to be a bit more aggressive. Then you will go in for an endoscopy. You will be injecting adrenaline at the base of the tear. Most of the time that alone will be sufficient to control the bleed. If required, you can also do cauterization, or he might even use the word endoscopic clipping. So any of these maneuvers can be done for controlling the bleed in malarious. To majority of cases, this would not be required because I explained to you that this is a submucosal tear. This also leads us to the scenario of what is the source of bleeding here. So we'll next talk about what is the source of bleeding in this particular case, because we're talking about the cardia and subsequently the tear going up to the lower esophageal sphincter. The source of bleeding in this case would also be answered as left gastric artery. This is the second time today that I've described the left gastric artery as a source of bleeding from anywhere. First I talked about gastric ulcer, then in malarious. The subsequent condition that can contribute to upper GI bleeding and a manifestation of hematemesis is called as Dulufoy's lesion. Well, it is not also the rare one. It is less common, but not the rare one. So my question that I put up right in the starting of this video saying which is the rarest cause is coming up at point number 6. I still given you sufficient window period. I've given you sufficient time to think about it. Dulufoy's lesion is an aberrant submucosal artery. Most of the time, you see, blood vessels are supposed to be present obviously in the gut, but they're towards the serosal side. If they're towards the submucosal side or the mucosal side, then what basically happens is that the churning action of the stomach can cause damage to these blood vessels itself. So aberrant submucosal artery is what we call as Dulufoy's lesion. It can cause a pinpoint bleed, which might be difficult to pick up initially. If he says what is the rare cause, your answer will be a vascular malformation. In fact, I gave you a hint by showing an image right in the starting when I was asking you what is the least common cause. You can see this appearance, no? The hint I gave you in the starting of this lecture was this particular image. This that I've shown before you is called as watermelon stomach, and this would be seen with a condition called as GAVE, that is gastric antral vascular ectasia. I showed this image actually 2 times to you. The superior image in this case, you can make out some protuberances of these veins. So this that I've shown before you is an endoscopic image of non-bleeding esophageal varices. The inferior image is anyway a watermelon stomach. Your answer would be given as what I've just jotted down before you. Let's just practice the full form. Whenever I write down short forms, I would personally advise you to just note it down on a slip-on pad, the full forms, because you never know when it might slip out of your mind. So if you write it once, then it becomes or tends to become a long-term memory. Gastric antral vascular ectasia is a vascular malformation that initially might be missed out because the lesions may not be so prominent as I've highlighted. Most of the time, the MCQ that will come on this topic will say the phrase watermelon stomach is found in. The answer would be given as gastric antral vascular ectasia. These are the usual causes that you encounter for upper GI bleeding, and that's actually a table in Harrison that I've tried to highlight. If he begins a MCQ of upper GI bleeding by talking about unrecordable BP, then first always talk about hemodynamic stability. Once you ensure that hemodynamic stability, then you are on the course to go in for fault finding of what could actually be present, and you must always look for a spleen. If it's present, it always tells you that it's gonna be portal hypertension. So at least two carry home messages here are: leading cause of upper GI bleeding POD, rare cause is gastric antral vascular ectasia. But if he mentions a spleen present in a person, if he says alcoholic, piece of cake, never a problem. But he usually will talk about a non-alcoholic patient, where I've given you the scenario of cryptogenic cirrhosis as well, and that definitely has to be kept in your mind. The next topic that I'll explain to you is hematochezia, which basically means fresh blood in the stool. The most common cause of this in MCQs should be answered as diverticulitis. Please remember the fact that overall in clinical practice, however, the number one cause is not diverticulitis, it is piles. Because piles is very simple an answer. The examiner knows that you will be able to get the question right, and he obviously does not want to make you feel so comfortable. That is why piles or hemorrhoids is not given in the options, and the answer would be given as diverticulitis. You are aware from surgery that hemorrhoids will be of the two varieties, that is external and internal hemorrhoids. We are discussing here about internal hemorrhoids, which are going to be responsible for painless blood or painless bleeding that will occur post defecation. You see, when it comes to external hemorrhoids, they are horribly painful. But when it comes to internal hemorrhoids, this is going to be a painless bleed. The bleed will, however, be occurring post defecation. So the term that will usually be given in the textbook will be flash in the pan. What I imply by the word flash in the pan is that the person has defecated already, and then there's suddenly a spurt of blood. And when this person gets up after using the toilet seat, that's when he sees all that blood, and it looks very, very scary initially to the person. Lots of these patients might even turn anemic because of this continuous loss of blood before they actually seek medical advice. Do remember the fact, painless bleeding post defecation. Why I highlighted that is, if he's gonna talk about an anal fissure is again gonna be horribly painful, and there would be streaking of blood on the stool. But in this case, there's gonna be a post defecation scenario of a painless bleed, which can be written in multiple choice questions as flash in the pan. If he gives this classical term anyway, you are familiar with it. Otherwise, incidence wise, I've already highlighted before you that internal hemorrhoids are relatively the number one cause responsible for this. If he says what is the best way for diagnosis of this condition, your answer would be given as proctoscopy. And now, when you put in a proctoscope, you will be able to see the veins prolapsing into the lumen of the proctoscope at 3 o'clock position, 7 o'clock position, and 11 o'clock position. If this is the area where the veins are prolapsing, then the technical term that we use for this is called as primary piles. Remember the fact that there are two separate things. One is primary and secondary piles. Second is gonna be grading of piles that I'll explain to you. You see, if the piles are present at any of the following areas that are marked in green, that is in between the areas of 3 o'clock, 7 o'clock, and 11 o'clock, then I'm gonna use the word secondary piles. So primary and secondary is mainly related to the location component. However, he can also mention regarding the grading part. I have seen a lot of people messing up with the grading part. So though this is discussed in surgery, let's do a quick evaluation here for the grading of piles. When it comes to grade 4, This person will say, doctor, it's very embarrassing. And he says, why it's embarrassing is because he says, doctor, after I've defecated, obviously there's bleeding, but apart from this, he can feel something coming out of the anus, which is actually the veins which are prolapsing out of the anus of this person. He will then say that I tried to push them back with my finger, that is digital repositioning. And he says that in spite of him pushing the veins back with his finger, the digital reposition fails. On the other hand, if a person tells you the same information that he goes to the washroom, there's gonna be blood at the end of defecation, then the veins come out. He tries to go in for digital reposition. Alphabet R here stands for reposition, but digital reposition is successful, then I'm gonna call it a grade 3 piles. However, when you talk about grade 2 piles in a person, he will tell you that veins prolapse out, but there's gonna be a spontaneous reduction. You see, this time he does not have to use his finger to push back the veins. I know you are familiar about this from surgery, but it's a quick recap here. When it comes to grade 1 piles, that would mean that this would be visible only on proctoscopy. Why I have spoken about it is mainly to remind you the fact that there was a question which said secondary piles or second degree. So secondary piles would mean the location. And when you talk about second degree, that would obviously mean the severity component. And obviously the treatment of this will be studied by you from surgery. I'll give a bit from surgery, like grade 3 and grade 4 piles, you will be going for surgery, that is a hemorrhoidectomy. On the other hand, when it comes to a grade 2 pile, you can either be going in for banding or cryosurgery. Cryosurgery is usually preferred nowadays because you are going to apply liquid nitrogen probe and the tissue will freeze and the pile will basically fall off. Can you tell me from anatomy/surgery the source of bleeding? Like I've highlighted in this discussion that whenever you're reading about bleeding anywhere from any part of the body, you need to know the source of the bleeding. Can you tell me the source of bleeding with respect to internal hemorrhoids? Well, you guessed it right. From surgery domain as well as anatomy, you know that the vein that's gonna bleed in this case is gonna be the superior rectal vein. That's again a question that they have asked in the exam. But because all this is very easy, so most of the time examiners are assuming that you are aware of this, and that is the reason why they love to ask about diverticulitis. Now, diverticulitis is again something that is less commonly seen in India because we Indians, even if we are non-vegetarians, we mainly eat white meat and in between we eat vegetables also. I'm talking about next a hardcore non-vegetarian, and this guy is eating beef on a daily basis. You can think of an American patient, you can think of a European patient. I mean, people who consume large amount of beef or meat on regular basis without intake of any vegetables, they would be suffering from constipation on long-term basis. And this constipation can then trigger development of first diverticulosis. Please appreciate the fact for anybody to develop a culitis, first he should be having a pre-existing diverticulosis. And why do you get a diverticulosis is mainly because of the constipation component in a hardcore non-vegetarian. I'm not talking about a recent onset constipation. You see, let me say a guy is 65 years of age and he started getting constipation for previous 6 months, that is worsening. It could be carcinoma rectum also. On the other hand, in this case, the constipation has been present for, let me say, 20 years, 30 years. I mean, a long duration constipation. He has tried alternative medicine. He is like an Indian patient. He has tried homeopathic, Ayurvedic. He knows all the brands. Allopathic, Ayurvedic, homeopathic, everything that he has tried. But the constipation is still very much present. And now this guy ended up with diverticulosis. And then from culosis, he can progress to colitis. How? Please remember that diverticulosis and colitis is commonly seen in the sigmoid colon. The narrowest part of the colon, you are aware that the most dilatable part of the colon is the cecum. Similarly, the narrowest part of the colon is the sigmoid colon. So, sigmoid colon takes the maximum impact in constipation. I repeat that again. The most widest and the dilatable part of the colon happens to be the cecum, and the narrowest part of the colon happens to be the sigmoid colon. So, here sigmoid colon is taking the hit. Once you are having this formation of diverticulosis, now in yellow I've shown these fecolates which are physically obstructing the mouth of the diverticula. Inside this, the bacteria will continue to multiply and keep on producing toxins, and these toxins can cause inflammation. So culosis is now having colitis, and God forbid, there's also a distinct possibility that if this perforates, then there's gonna be even contamination of the peritoneal cavity. There's going to even be a fecal spillage. I mean, you are aware of the fact that the worst kind of peritonitis that you can ever encounter is a fecal contamination of the peritoneal cavity. That can happen in this case, and that is why it's important that you are able to pick up this condition relatively early. So most MCQs that will come on this topic will describe a geriatric age group person. He will initially talk about the fact that this guy is having constipation, obstructive symptoms in the form of constipation will make you think in terms of carcinoma rectum. But as I have sensitized you, if it is gonna be a recent onset manifestations of constipation, this guy was having regular bowel habits all his life. It's just that recently he started having constipation. Yes, that is when you will think in terms of the fact that there could be a malignancy, but this guy has been suffering from this for a long duration. So I'm saying the word chronic constipation and then non-vegetarian person. Today when he came to my clinic, he had severe left iliac fossa pain. It was excruciating, but initially I did not take this guy seriously because if I know a person is having constipation, left iliac fossa pain, he may not have passed stool. But what this patient said next immediately sent the alarm bells ringing in my brain. He said, Doc, there have been 2 episodes of fresh blood in the stool, and that is making me think what's going on. I mean, this guy is having constipation, understandable, but he's never had fresh blood in the stool. So whenever you read this kind of a profile of a geriatric age group patient presenting with excruciating left iliac fossa pain and hematochezia, it is diverticulitis which is to be thought. He will ask you what is the next best investigation. For abdominal emergencies like diverticulitis, you can do a CT abdomen and can make a diagnosis. Here I have seen a common mistake being done by a lot of guys. The common mistake done is they tend to answer barium enema. Now please remember the topic that we are studying at the moment is diverticulitis. That's the medical emergency. But diverticulosis per se is the one that is picked up with barium enema. So you need to get it in the right perspective. If I simply asked you how do you identify culosis or diverticulosis, barium enema, colitis, that's gonna be answered as CT abdomen. You see, because this is a very classical figure, you can see the outpouchings which are present in this case. You can definitely make up the appearance of these sacculations in the sigmoid colon of the person. So this physical appearance that I've highlighted before you is one that is technically represented as sawtooth pattern. Most of the time, barium enema is an answer because most guys have read diverticulosis even in radiology. The sawtooth pattern on barium enema, as I've shown here on an enlarged view to you, is gonna be a very classical finding for culosis, but culitis is a medical emergency for which a CT abdomen should be done, and God forbid, if you fail to diagnose it, then a fecal contamination of the peritoneal cavity will occur. That would be the worst kind of peritonitis that you can expect in any patient. For the treatment of diverticulitis, it will depend on whether the fecal contamination or the peritoneal cavity has occurred or not. Assuming the fact that you made a diagnosis earlier, if it's a localized disease, a localized abscess, person will be made nil per orally. IV antibiotics will be given, person will be put on IV fluids, then gradually introduced on liquid diet, semi-solid diet, then subsequently he will resume normal diet with dietary rehabilitation. For treatment of cholosis, you can again read it up from surgery because the topic is having a surgical domain as well. But I again want to highlight the fact that whenever in the exam you read the following information, if you read, it is written sawtooth pattern on ECG versus sawtooth pattern on EEG versus sawtooth pattern on a CT abdomen, you know the fact that the answers will definitely be different. Sawtooth pattern on ECG is always atrial flutter. That I know most guys can answer spot on. If he says sawtooth pattern on EEG, then your answer would be REM phase of sleep. Whereas for CT abdomen, we have just discussed it right now. It's going to be answered as diverticulitis. Do take care of this silly mistake that can occur with people, colitis versus cholosis. That